Hi, everyone. I'm Stephani Hatch. I'm a professor of sociology and epidemiology at the Institute of Psychiatry, Psychology, and Neuroscience at King's College London. I'm really sorry that I wasn't able to be there with you today, but I'm really excited to present this keynote, and I thank the organizers for inviting me. I just want to say that I'm sure that you're having a fantastic time here at the conference. And there's more to come. And today we're going to be talking in this session around the importance of cultural safety to improve outcomes. And these are going to be lessons that we've learned from mental health care. So what do we already know in terms of the inequalities and inequities in mental health services? Well, really a lot of this work, and there's a wide body of work, has focused specifically around access, experience, and outcomes. And these are inequalities that remain after adjusting for levels of need, for demographic characteristics, as well as socioeconomic indicators. So we're talking about robust associations, and really identifying, mechanisms. Where do we need to focus on, and what are the mechanisms that may be at play? And one of the pieces of work that has really focused our minds in terms of mental health services is just starting from the issues around access. So thinking about the evidence that supports that those from racial and ethnic minoritized groups are more likely to be referred through community services rather than their GP, the first point of entrance into the health system. So we see this consistently, and we know that these inequalities appear to be widening over time. People from racial and ethnic minoritized groups are less likely to receive what they consider the appropriate help for both severe and more commonly experienced mental health problems. So thinking about depression and anxiety, for example. More often than not, we find in both qualitative and quantitative data that medication is made more readily than talking therapies. So we get this, overall pattern of just being less likely to even be offered talking therapies. And then, of course, less likely to complete talking therapy. And I say, of course, because it becomes very clear that there are some issues in terms of what may be culturally safe or culturally appropriate within these services. So now some of the common issues that we see globally in the international literature involve the lack of acknowledgement and experience of the experiences and the impact of racism right over the life course and its pervasive impact on mental health. We find people talking about the poor understanding of the intersection and the nature of the complex identities, particularly regarding migration history. We've spoken about the lack of appropriate treatment being on offer, but also the lack of involvement of service users, of carers and their families in treatment and decision making. And really what we're focusing in on today is the number of interventions that are available really being based on Western concepts of mental disorders, which may not be appropriate for all racial and ethnic minoritized groups with regards to their mental health. So often not aligned with the cultural perceptions of mental health that vary, and little to no acknowledgement of the diversity within and between cultures. And so here I've given some references. These slides will, of course, be available, and on the slides that we put on the website, I'll make sure there's even more information. But I wanted to note the work of Professor Janet Helms, so a Black psychologist from the US who'd been doing work, a lot of the work in this area for many decades, and whose work is very informative. So we're starting with a really good knowledge base. But let's back up a second and really think about what we mean by culture. So broadly speaking, we know that the definitions of culture and the conceptual frameworks are going to vary across disciplines. But what we do know is that it is socially constructed. It's linked to our identities, our multiple identities, and evolves over place and time. Culture is dynamic, and it's interrelated and entrenched in social and historical context. It's rooted in our beliefs, our social interactions, and treatment and interventions that consider language, experiences, and context in ways that are aligned with service users' cultural experiences, beliefs, meanings, and values. Now, when we talk specifically about cultural safety, we're really referring first and foremost to the work of Ramsden, who co-developed cultural safety and this conceptual framework, as a Maori nurse scholar with Maori communities in New Zealand. And this was really trying to focus on cultural change all the way through and across sectors that come to influence health. So really thinking about healthcare, not in a silo, but also thinking about education, about research, about policy, and working towards exposing and addressing some of the structural issues, and very key to this, the power imbalances, the cultural dominance, and the racism that a lot of service users have experienced right over the life course and across generation, and of course across generations. So there's so many words going around in turn that are related to this. You would have heard of words like cultural competency or phrases like cultural competency or culturally adapted. What do these all mean? How are they related to each other? So I've just put up one version of what these definitions might look like. You certainly can go in the literature and explore this a little bit deeper. But I think it's really important, and coming across the term cultural humility, really important that we start there, because this is really about self-reflection and really understanding what's going on in terms of our own biases, and taking stock of that and how these biases may come to influence service provision and service engagement. And then cultural safety, we've spoken a little bit about that, but really looking to create a safe environment, one in which we are establishing respect, where we're thinking about the meaning of the work that we're doing collaboratively, the knowledge, the living and working together. And I think these words are really important, really around dignity, respect, and really truly listening. And then, of course, you're all very familiar, I hope, with cultural competency and really thinking about how services can be culturally adapted. And so I've given some sense of that here. And again, it really starts to promote many of the things of taking this forward. What does that actually look like? But I also want to emphasize that it is really, there's a need for there to be this promotion of anti-racist policies and practice alongside it. So a culturally safe environment would be one that acknowledges and respects every aspect of someone's life, doesn't move to lessen it or ignore someone's identity, and really focused on the uniqueness or the power that we each have as human beings, that respect and that right to healthcare as a fundamental right. But notably going further, really focusing on the social and structural inequities that are determined and felt by both service users and healthcare practitioners. And one of the things I liked in reading about Ramsden was that there was this vision of nurses as agents of social change. And I think that applies right across the board to everyone in the room today. But really thinking about, as a healthcare professional, as a healthcare practitioner, what can you do to be an agent for social change? Now, there's always a question of effectiveness. And I'm glad to say we've got some good examples here of recent systematic reviews that have really brought together some of the key literature in supporting the idea that there is evidence for the effectiveness of culturally adapted interventions in mental health services. One of the main, just looking at the main findings across these studies, we know that racial and ethnic minoritized groups will benefit from these adapted interventions, and definitely has the potential globally to reduce the health burden of depression, in one example. In terms of also challenging, what types of programs might be effective, we do need more there. We need some consistency around how cultural adaptations are defined. We need people to be much more transparent about what they're doing, but also really getting services to think and consider, also bringing into that context that I mentioned earlier, organization-specific adaptations. Now, this area is not without critique, as you can imagine. And a lot of people have done some reflections on this. You know, the terminology has been criticized for conflating culture with race and ethnicity. This assumption that culture is fixed and can be learned at any given time. There's also a real strong and important critique around individualizing culture, because as I said earlier, this is something that's collective, it's social. You know, we really want to think, you know, about these sort of systemic inequalities and how this sort of feeds into that a little bit more. So that, you know, it's important to not only think about how groups might benefit, but also where there might be areas of improvement in terms of this area. So I just want to talk, you know, in terms of actionable insights next. You know, what is our goal? Our goal is to meet the needs of racial and ethnic minoritized communities in mental health services. And to do that, we need to address the structural racism. And this, I'll give an example, can be done through organizational competency frameworks, for example. We want to provide a culturally safe and appropriate mental health care. We want to integrate explicit anti-racist practice in mental health care, working with communities, with carers and service users, and include and really focus on this being inclusion as a practice among all of those involved, all of the staff. So really not focusing on one group, but really thinking in a system-wide approach, how do we actually make this change? So I'll give some examples, and the first one I want to point to is an example of a national initiative. So this is the Patient and Carers Race Equality Framework, or also known as the PCREF. And this work has been led through the Advancing Mental Health Equality Strategy coming out of that, and also, you know, really tightly linked to both the national and the local, as we'll hear. It's got three components. So the work that Dr. Jackie Dyer and her colleagues have been doing at NHS England and Improvement, really focusing on these three components. So the statutory and regulatory obligations, so we talked a bit about that, the organizational competencies, and really important here, the assessment and feedback tools that are needed to make sure that everyone is involved and included in this process. So really thinking about the policy. So we've got these, you know, policies in place, and what are they aiming to do? Really focusing in on those things, again, that we identified from the research literature. The patient and carer access, experience, and outcomes in mental health services, and wanting the communities to be central to the PCREF development. So right now there are 4 PCREF pilot sites, as well as some early adopter sites, all aiming towards the, you know, these same goals. And as a part of this, a very important part of this is the development, the co-development of culturally appropriate advocacy service feedback. So working with local communities towards this end. And if we think about how this then translates to the local level, I'll take the example of South London and Maudsley NHS Foundation Trust. They're one of the pilot sites. And they are very much focused around being a partnership with community members, with volunteer and community organizations to achieve this change. So really working in partnership to achieve anti-racism and equity. And one of those organizations is Black Thrive Lambeth. And what that is really focused on, again, is working across sectors, taking a systems approach to address the inequities impacting the mental health and well-being of Black people in Lambeth. And this is the group most affected by these inequities in this part of London. So working with communities and statutory organizations, volunteer groups, as well as the private sector. And the 4 things that they're focused on is generating evidence. So through that, developing a very strong partnership with the ESRC Centre for Society and Mental Health at King's College London, being a community host for the PCREF, as well as doing some work around reviewing the various care pathways so that they're more culturally safe and appropriate. And this may involve, for example, developing new measures such as the Cultural Capability Questionnaire. Reimagining services, so that taking, again, this co-design approach and piloting these culturally appropriate peer support and advocacy. So CAPSA, working in inpatient wards as well as in community settings to work together to make this change. And of course, this involves retraining the workforce. So thinking about the use of and delivery of emotion emancipation circles in partnership with the UK Association of Black Psychologists. Hearing really great things about this work, and I hope others will adopt it as well. And then, of course, informing policy and engagement with the community, bringing the voice of the community into these policy spaces. Another organization that I want to highlight is the Institute of Women in Ethnic Studies. And here I've just have a clear visual of what their organizational values are. And at the top of that pyramid is healing. You know, healing is the revolution, as Dr. Denise Shervington says, and is really a motto of the organization. So this is an organization set in New Orleans, but is certainly does work nationally as well as internationally. And they focus on creating and delivering culture-centered initiatives, anti-racist policies and practices, and really focusing on health as a human right. So these are the three areas that overlap and greatly impact women and their families. So their priority populations, as I mentioned, are women and children and their families. And these are just some examples of some of the work that they've been doing. So really focusing on what are the experience of Black and Indigenous people of color and communities, you know, doing work around maternal health, doing work around health and healing and around cultural safety with migrant families and asylum seekers at the border, at the US border, to really work towards helping and working together with those who are most vulnerable to these inequities and trying to make change on a local level. But also, again, as I said, sort of adopting what works, readapting it at national and also in international settings. Now, just to say that they're really focused on a trauma responsive practice, and we hear, you know, the words, you know, used around being trauma informed, but I think really being trauma responsive is key here. So really, these are really what they focus on in terms of being trauma responsive, not just being trauma informed. So really taking all of these in, these overlapping issues, and really trying to embed them in all of their programs. And finally, I just will leave with just some actions that we can all think about. So just in terms of cultural safety and what that means in terms of related approaches, I think we can all agree that we need to start with the explicit acknowledgement of racism. And so really thinking about, you know, racism as an underlying driver of inequalities, and you will have heard a lot about this in the conference, and I hope that it really sinks in to some of those decision makers in the room. That this really has to be not only within health and social care, but also in the education curricula, in all institutional strategy, as well as integrated into all policy. So it's not just about, you know, overt actions of racism, but also thinking about the more covert actions and openly acknowledging and reflecting on the meaning of whiteness and how whiteness as the norm within the NHS impact both staff and patients. Now, social context is key here, and really thinking about, as I mentioned earlier, services needing to consider the organization's specific adaptations, but also starting to question, you know, whose culture are you making safe, which culture? But in the process of doing that, being very mindful that division is a tool of racism. You know, we see it more often than not, and it's just to remind ourselves that we collectively need to come together with this in mind. So being aware of ways in which race and ethnicity also intersect with other characteristics, because we're complex people, right? So really thinking about that, but really at the heart of this, what can we do around this issue? with regards to race, which has been so unattended to over time and across contexts. And then thinking about drawing on the learnings and recommendations on what works, with regards to training and organizational approaches. There are many examples out there. So if you're at a loss of where to start, when I put these slides online, I will give you some sort of lead-in, some references to get started, as well as thinking about integrating this teaching into health education and training pathways from the very beginning. We know from some of the research that I do in my health inequalities group with students that it doesn't take long for them to be socialized into a environment in which they find negative behavior and racism to be wholly acceptable. And we have to stop that pattern. So we don't want to teach them that that is the way forward. So integrating it early. Engage in further evidence generation and research. And I separate this too, because we can all have a part in this. Really thinking about how we measure these outcomes, how we consider organizational factors within your own organizations. But there is good evidence out there. Now, most of it is focused around short-term gains. So we want to also be thinking about longer-term behavioral change and what that means in relationship to patient or service user experience or adherence and outcomes. And then finally, just thinking about what is required and really placing emphasis on promoting inclusive and psychologically safe services, not just services, but also workplaces, and addressing issues of power and equity along the way. It must be co-designed, and it must be adapted alongside these other, related terms. So read more about cultural humility around awareness, competency, and responsiveness. And all of this in response and in combination with anti-racist policies and practice. So focusing on development and evaluation of system-level interventions, not just in one trust or one healthcare practice, monitoring the progress through patient and carer feedback, as well as, again, at the structural level around organizational competencies, integrating this into your codes of practice and adherence, making sure that the adherence is appraised and that there are associated actions, monitoring and taking action where there is resistance and collusion, and finally, holding leadership to account. I can't say it enough. We must do this. People who take on leadership roles are there to lead everyone. So thank you very much for this time. I'm really sorry that I can't be there for the discussion. I'm sure it's going to be great. Here is the information. Again, don't forget our hashtag for the conference. And I've also put up more information about my research group at King's College London. Please do get in touch. Thank you very much.
Thank you. Thanks to Professor Hatch and to lead the panel that will discuss these issues. I will present again someone who needs no introduction, Lord Victor Adebowale.
Thank you very much. Can you hear me? Yeah. Okay. So we've got a panel discussion. That was great by Steph. Introduction to the issues by Stephani. It's an issue close to my heart. Any of you come across the organisation NAFCIAT? NAFCIAT, yeah, it's interesting, isn't it? You know, the cultural, intercultural. Oh, I do the usual one. Is that on? Okay. Is that on? Oh, bloody hell. Yeah. Yes, so NAFCIAT, the Intercultural Counselling Service, one of the few of its kind in Finsbury Park, was one of the few organisations set up to create cultural safety in mental health and counselling provision for black and minority ethnic people. And not many people know about it. There are lots of presumptions around the delivery of healthcare and mental health care in particular. I personally have been involved in at least 3 government programmes designed to drive better mental health care to black people. Breaking the Circles of Fear was the first attempt. All of them have made tiny steps forward and then have been withdrawn. Usually, in my view, because of professional resistance, a lack of leadership from the top, not necessarily a lack of resource, but a lack of appropriate resource allocation, so that we carry on. I think it's unacceptable that black people still have poor experience and poor outcomes in the mental health service pretty much everywhere in this country, although it is true that recent evidence of the IAPT, Increased Access Psychological Therapies, gives us a glimmer of hope that black and minority ethnic people can actually deliver receive an equitable service from mental health services when they are designed properly. I think IAPT has worked not because it was designed necessarily to work with black and minority ethnic people, but black and ethnic minority people found it a more appropriate and accessible route to mental health. So we've still got a way to go. So we have a panel. We have a way to go. In thinking about Stephani Hatcher's contribution, was considering the notion of values-based practice and its role in the training and delivery of healthcare across the piece. I won't go into the treatise on values-based practice, but there is an encyclopedia of values-based practice, the work done by Bill Fulford and others. I think there's something fundamental about how we train clinicians in this country that means that they simply don't understand the role of values in their interaction with patients and communities, and they presume far too much, and that's allowed to continue. So, enough from me, because I can bang on all day about this stuff. Let me introduce the panel. We have Heather Nelson, and please come up and take your seat. Heather Nelson, well known to me, Chief Executive of the Black Health Initiative. She's an RHO board member and chair of the RHO Stakeholder Engagement Group. Welcome, Heather. Dr. Priscilla Reddy from South Africa. This is a great title. I want a title like this. Extraordinary Professor. It'll do for me. I think it's fantastic. You are extraordinary. As soon as you say Dr. Priscilla Reddy, South Africa, that's extraordinary enough for me. Extraordinary Professor in the Department of Social Works Faculty of Community and Health Sciences at the University of the Western Cape, a member of the RHO's International Advisory Group. And Steve Gilbert, who's an anti-racism and lived experience consultant and co-chair of the RHO Mental Health Working Group. So, what we're going to do is we're going to ask each of you to make a contribution. I think 5 minutes, something like that. And I'll start with you, Steve, if that's okay, because I know you want to speak from the lectern, which you are perfectly allowed to do. You don't have to. You're welcome to speak from the lectern if you want. And then, if that's okay, we'll hear from you, Heather, and then we'll hear from you, Doctor. Is that all right? Crack on.
So, to those in the room and to those watching online, can I ask you all to stand up, shake it out. It's been a bit of a marathon so far. Taking some deep breaths. Right, we're nearly at the break, but we've got some magic to get through first. Right, take a seat, please. And before I begin, I want to ask you all a question. Can you raise your hand if you know personally somebody who has experienced some form of mental illness? Thank you. Can you raise your hand again if you feel that their race and identity played a role in their experience of mental health care? And can you raise your hand for a third time if you believe that they deserve a better level of care and treatment? Say aye. Say aye. Aye. Thank you. So a little bit about me. In 2008 and 2009, I had major depressive episodes and made attempts to take my life. In 2010, I had a manic episode, was detained by the police under Section 136, and subsequently detained under Section 2 of the Mental Health Act. I spent a total of 21 days in hospital, which is unfortunately short by many standards, but long enough to understand the impact the mental health that can have on a person's life. I'm biracial, my mother is white, and my father's side of the family are black. And on my father's side, there are at least 3 of us who have been sectioned, including my own father. It's safe to say that serious mental illness and the interrelation with racism has destroyed my relationship with my family, and the way in which mental health services operate has had a significant role to play in this. I have a diagnosis of bipolar disorder and complex PTSD, the result of psychological abuse at the hands of my parents and siblings. And over the past 10 years, I've been a typical service user, regular appointments with my psychiatrist, my community psychiatric nurse, talking therapy, lifestyle changes, and regular medication, including lithium. I'm still very much a user of mental health services, although for a number of reasons I've just gone private with much of my care. And over the past 8 years, I've used my experience of mental illness, mental health services, and racial discrimination to develop various work streams. And I'll just give you a few highlights. I was a lived experience consultant to a program called 300 Voices, which developed a sophisticated engagement model to bring together service users, families, mental health staff, and the police to really explore and challenge why it is our young black men are more likely to come into health through a criminal justice route as opposed to a purely health route. I was privileged to be one of the vice chairs of the Mental Health Act Review and welcomed the draft Mental Health Act bill a few weeks ago. I chair a diversity council for a digital mental health organisation supporting an ambitious anti-discrimination strategy. I was a trustee of Mind, one of the biggest mental health charities in the country, and I'm still a trustee of the Association of Mental Health Providers, a phenomenal organisation. I'm really proud to be one of the vice chairs alongside Jess Bamra, who I know is watching online and couldn't be here today. And I want you to understand that I list my achievements not to blow my own trumpet, but to highlight the fact that people with serious mental illnesses can and do work at the highest levels and can hold their own with the big hitters in the mental health and social care world. And I believe that my appointments were based not only on my experiences of mental illness, but an ability to draw on a highly effective skill set, providing value to the process. And I want to share an anecdote from 300 Voices. We took our engagement model to an away day for psychologists. And as you'd expect, it was quite typically full of fairly young females. And we split into 4 groups and we were sharing the model with them. And during the course of the session, one of the psychologists turned to my mentor and said, "Well, I just don't think that black people are psychologically minded." My mentor very calmly said, "Can you explain that?" And the psychologist responded, "Well, if you look at the data, it shows that there's a significant underrepresentation of black people in our psychological services. Therefore, they don't need our service." And he even calmer said, "Are you looking at the data wrong?" And she said, "What do you mean?" And he said, "What if it's to do with how IAPT has been sold to our black patients? What if we're unconsciously telling black people, this is not for you? What if the reason that the data looks, what if the reason the way data looks this way is that we're assuming that black people don't want or require psychological therapy?" This runs deep. And I want to let that sit with you, and then I'll hand over back to Victor. Thank you very much.
Heather Nelson.
Is it morning? Yes. Good morning, everybody. So I'm the Chief Exec of Black Health Initiative, known as BHI, to partners, friends and colleagues. And the organisation concentrates on inequalities and inequities in education, health and social care. And we were very content initially to just work at grassroots level, working with the communities that needed our services and who informed our services. But we quickly realised that although we were working very well operationally, strategically it wasn't being teamed up. So as much as we were referring our community members, individuals to services, those services were not shall we say, culturally competent in regards to what they were doing with our service users. So the service users and individuals were coming back to us and basically complaining because, again, a trusted organisation was sending them to larger white establishments who were treating them in a racist, non-compliant way. Part of the programme was about mental health, and I'm going to make a distinct separation. We talk about mental health, but I'm going to talk about mental ill health because there is a difference. Now, what I can deal with today might be different with what I can deal with tomorrow. You know, we all know the saying, you know, the one straw that broke the camel's back. That can happen to any one of us at any given time. And we need to recognise that. And that's something that we speak to our communities about, to try and break that stigma that they themselves have around mental ill health. But more importantly, we started to speak to the service providers about the way that they were treating those who were black and brown that were coming to their services, and the negative stereotypes that they immediately had when they saw these individuals walk through the doors. We then actually said to them, what we needed to do was, there was those who were already established in the services, but let's have a look at the next generation of clinicians, psychotherapists, etc. And what BHI has been doing for the last 3-4 years is actually being a workplace placement for those who are going into the medical service. And we had to do that to try and break down step by step the negative stereotypes that were being perpetuated over and over again, which led to misdiagnosis. And I'll give you an example, a quick example of misdiagnosis. And I know you'll find this interesting. So, there was an incident that happened within a community centre. The police were called, and unfortunately there was some arrests being made. I don't think that was needed, but there was arrest being made. A woman who was very much in faith, and for those of you who know about our evangelical faith, she was born again. She was a born-again Christian. She realised that her grandson had been arrested. Straight away turned into tongues, started to speak in tongues. I knew what she was doing, I knew what was happening, but there was a social worker there who straight away rang and said, we have a woman who is showing psychological issues, and she's in psychosis, she's in crisis, we need help with this woman. Now this woman, she was in tongues, she was praying as she was in tongues, and I said, no, you don't need it, it's okay, it's fine. They pushed me away, and I said, listen, you don't need to call the help. Needless to say, they still called, they came. They sectioned her. Not only that, when they took her away, they gave her medication that was not needed. And again, we've got to look at how they medicate us as well once we're in the mental health system. You know, the stereotype about we're strong, so we need to have stronger or higher dosage of medication. To get straight to cut the long story short, in essence, the woman was released. She was angry about how she was treated, rightly so. I said to her she needed to complain. Because when we let these things go without being addressed, they happen time and time again. She didn't want to complain because she said, what's the point? Nothing's going to change. Well, I went back to the main mental health service provider, and I gave that definition. I gave this story to them. And the chief exec, who will remain nameless, gone now, turned around and said, well, obviously, she behaves in that psychotic way. She deserved to be sectioned. I say all this because I do believe exactly what Stephanie Hatcher said about cultural humility, cultural understanding, but also responding to trauma, because that in itself has traumatized that woman. Yeah? And when the others had seen this happen, you now have a mistrust again within service providers. Mental health is an issue that we all come across, be it mental good health or mental ill health. We've just got to be aware of the service we're providing to actually influence the change in a positive way. Sit in as many boards as we are able to make that difference. You cannot make a difference from outside, you have to make the difference within. And also, let's look at partnership working, effective partnership working. You know, I know the NHS are making a difference, but you can make a quicker difference when you work in partnership with those who already have the trust of the communities you wanting to reach, the understanding of the communities you want to reach, and also the learning.
Thank you very much. And finally, Dr. Reddy.
Thank you so much, and thanks for inviting me to this panel. I think so much has been said with the presentation, and thank you for sharing so honestly and openly the issues that you'd shared. I think I want to bring in a slightly different angle, and I'll be very brief. I want to go back to the data collection and how we collect data from our communities and the impact that data collection process has on the mental health and the cultural beliefs of the people you collecting the data from. I can remember on my early days at the MRC developing an instrument and wanting to collect data, and it was around sexual behavior, knowledge, attitudes, and social norms. And I had to present it to a committee, and the committee believed that that data could not be collected with full integrity from isiXhosa-speaking people who were the target for that. So I just want to raise the issue of translation, cultural tailoring of the information, and actually, even though instruments and questionnaires might be tested, they might be pre-tested, I think it's very helpful to get good quality data if we do that again with different communities, taking into consideration their mental health circumstances, their cultural beliefs, the social norms, the impact of that, and the legacy impacts on that. For example, we collected data together with one of my PhD graduates, Dr. Feziwe Mpondo, and she collected data from Xhosa-speaking, heterosexual Xhosa-speaking women in the Eastern Cape. And we were using an instrument that we had translated. However, that instrument proved to be wanting because we did not take into account the cultural sensitivity and safety of Xhosa-speaking women living in poverty in the context of the legacy of apartheid and racism that Tony described earlier on. Thanks.
Excellent contributions, I think, from everybody here. I just want to, because two of you talked about or gave examples of interactions with the professionals, in inverted commas, actually given your stories. And I'm curious about how cultural safety can be built into training. I mean, this notion of cultural safety, is it a training issue? And if so, how do we get it scaled? I mean, how do we make a scale issue of it? You gave an example of your organisation, which is powerful. You punch above your weight. But it's drip in terms of you gave an example of your, it's an appalling conversation that you had with somebody who calls themselves a psychologist. And I'm just curious about what the views are about the training issue, the basis on which people actually enter the profession. Perhaps we might start with you.
It's a really interesting question. I think for me, I'm really wary of training. This is a how do we spend our time? And I'll give you another example. My cousin had a psychotic episode and ended up being sectioned, and she was in a ward that was the floor above the ward I'd been in. And there was an interaction with the senior nurse on the ward, and the senior nurse turned around and said to me, "You need to understand how things work on a ward here." And I didn't say anything. My friend said, "He does." He was downstairs. And her jaw dropped and hit the floor. And I think part of, and this is not me giving anyone a pass, but it's also me kind of not assuming that this is, on the whole, deliberate. although there certainly are cases where, you know, behaviour is deliberate. I think people are just so in their roles that they never get chance to come up for air. They never actually, and we all need it, just to, and build it into your work. What is it we're doing? What is our primary task? What is it that we are here, who are we here to serve? And I think one of the biggest issues is that if you're working, certainly in a front line where you're seeing people at their most unwell, and if you're on wards where you've got a lot of black people, and you know, black as inclusive for all racialized groups, that actually you never see them get better.
Yeah, okay. I'm keen to bring everyone else in here, but on this issue of training, I understand what you're saying, but obviously if those people on those wards aren't trained to actually see black people as basically patients, humans, then that's an issue. I'm just curious about your response to the training issue. How do we get to scale? And I'm going to come to you.
I think there's different ways of training, and for us, we identified that training needed to be on the ground. You needed to come out to us, to the communities, to understand the communities. It wasn't a case of going to a lecture room and listening. And you know, when you have that workplace placement within communities, it's powerful because you see different people coming to access the services, the way they speak, even if English is their primary language, the way we speak is different.
But would there be sorry to interrupt, but when I mean train, I don't mean academic lectures. I mean, is there a way in which we can build in the training of all mental health workers, regardless of whether they're psychiatrists, that they all come out and do placements?
I think that would be an excellent idea for all those who are providing services to go out and spend some time in the communities they're going to be paid to serve and understand them holistically as individuals. But most importantly, if we started off with a baseline of respect, you know, if we respected each other and saw each other as equals, that is a phenomenal starting point.
And that's a valence issue, isn't it? So, Dr. Reddy, you talked about information data and information, and I'm curious about whether you have experience of this information and data being used in the development of mental health professionals in South Africa.
I don't have much experience, but my observation would be that mental health materials are developed from a strong biomedical perspective, a biopsychiatry perspective, and the social science and behavioral aspects are limited, and the respect aspect is limited. And of course, going into a black community and collecting data of how people respond and how they treat mental illness and how the culture responds to it, how the family responds to it, would be limited. That would be a very progressive way of doing things, and my hope is that we would move in that direction. But I don't think those non-biomedical mechanisms are in place as we speak. Because you'd have to do it in a different language. Then the training programs would have to be run in isiXhosa, in isiZulu, in Pedi, because the notions, the concepts that those languages hold together, I don't think warrant a simple English translation.
So I've been told I've got to close, which is a real shame because I feel we've only just opened. You know what I mean? But before I do that, I want to give last word to my panelists. Just one sentence. What would be the one thing that you would recommend that would basically move the needle on safety and in mental health? Just let's start at this end. Just one thing.
More lived experience involvement at a meaningful level.
A more involvement of the community that you're collecting the information from in a respectful, non-racist way.
The willingness to understand your service users, those who enter into your services, and respect.
Well, I think I'd like to leave the audience wanting more, and I think we've done that. Let me hand over to Yvonne Coghill. Thank you very much to our panel. Thank you.
Thank you. That was superb. That was excellent. So thank you so much. listening to people's lived experience and actually thinking about how we work with our communities, what we need to do with our communities in order to get better services is something that I've been hearing quite a lot this morning, and it's something that we don't do in the NHS as much as we should do, because I think we believe that we know the answers, and so we go out and do to people as opposed to asking people what it is that they need and want from us. We have a film now, very, very quickly, but what I want to say to you is after the film, we're going to go straight out to coffee. I'm supposed to remind you that there's going to be a session after the coffee break at 12 to 1, that people can go into a breakout room on mental health to continue on talking about these issues. And I'm telling you this now so I don't have to tell you this when you get back from coffee, so that you can actually have a longer coffee break, because I realise how long you have been sitting and you must be getting quite agitated by now. So I'll come back and tell you a little bit more, but not as much as I would have told you before. So let's go to the film.
Hello and welcome. This is my documentary to discuss long-term COVID. My name is Harjit Marwaha. I'm 49 years old, from Birmingham, West Midlands, and I'm a government employee for civil service. So in this documentary, I'll be actually talking about the implications, the aspects of long-term COVID, and also we can look at the failures and also what improvements we could advise or put forward to look at trying to, if the service was vulnerable at that point, to try and strengthening this service to help others through this long-term COVID. So on 19th of December 2020, I fell ill. I had a severe headache, my chest, I had breathing on my chest, and I was feeling very poorly for 24 hours. I had diarrhea. I rang the 111 service at 6 p.m. on the Sunday, the following day, and they said it is gastroenteritis, which I have suffered before, and there's no need for you to do a COVID test. But because of my work implications, I did a COVID test, and by the Tuesday, the 22nd of December, I was diagnosed with COVID. Some of the aspects of that COVID was that my wife was very ill in hospital. The ambulance came to check me, and obviously we had one. They did all the checks and everything, and her breathing readings on the oximeter was lower. So she ended up in hospital. I just had the normal 94, she had a 92, so they took her to hospital. And I still remember sitting on top of the stairs when they were taking her away, and I was so lonely in the house. I was absolutely lonely. I didn't know where to go, what to do. For the 14 days, I had a support network of my friends dropping food off. We had a table outside. And it was a very, 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 very tough time on my own. Mental health issue as well, because at one point she rang me in the middle of the night saying that I'm going to go into ICU, and they're asking whether the husband can come down. And obviously, I was poorly myself. Looking at, I couldn't support her. I was here on my own. And then when she came through, so that was a really, really tough time to look through. So I was off sick, and then on 7th of February, I was feeling really ill. I rang the doctors on the 15th of February, and I said, my left shoulder is swollen, my right foot is swollen. So then they sent me emergently to hospital. The diagnosis they came out on the phone was I could have had a stroke, or it's something leading on to those terms. So when I ended up going to the hospital, they did a BP check, they did a 90-minute blood test, and also they did a COVID test, which the result would be after 24 hours. And then what happened is that the doctor diagnosed me on his report as having long-term COVID. He saw nothing wrong with the lungs, he saw nothing wrong with the tests. He said, you've got long-term COVID, it's going to take up to 18 months to 24 months for this recovery. It's going to be, as you want to look at it, that is the minimum recovery time, because it's quite unknown. COVID's unknown at that point. So then the next day on the 16th, I received the text message that was COVID positive again, which put me back mentally and physically because I was ready to go back to work. So then I had a sick note till 29th of March, went back to work on a phased return. It was quite tough. I was doing 4.5 hours at work, and how long-term COVID comes in is the minute in the first week when I finished my shift, I finished at 2 o'clock, and by 5 o'clock I was in bed till the next morning, 8 o'clock. So this is it. I was feeling very tired, a lot of pain. The one thing with long-term COVID is, one of the aspects of it is that when it's an on and off switch. When it comes on, the pain is severe, the fatigue is severe. I feel very tired. I feel very sleepy. I lose all the concentration as well. Body aches and pains are there. It's feeling drowsy. There's no concentration on anything. You have to think 5 steps to do 1 step of any action you do. You have to be organized. I started writing things down on paper to try and remember. It hits you like dementia because you have to start writing things down. I've got this appointment today. I've got this to do. I've got that to do, and it would be hanging off the walls, just making sure that these things got done. And it was a reminder. Right, that's the date. That's the time. We can do this. So that is the first question, quite answered, straightforward. And then obviously I got diagnosed with COVID now on 22nd of June. So you've got me at a time now that I can say what type of different practices have come in and what has changed from my original diagnosis to now, which is 22nd of June. So I'm recording this whilst I'm off with COVID. So the diagnostic I got now is I had a headache, had diarrhea, had temperature. My teeth are hurting this time as well, and I've got a bit of gum pain as well. So that's the diagnosis I've got. So there was no patient contact. These days, we can use WhatsApp, we can use telephone appointments, you can book appointments with the doctor, he can speak to you face to face. So they weren't there. I had to ring the doctor. I had to ring the NHS specialist 111. You can ring us and use our service. That one initial call could have helped this service or helped me a lot better because I felt I was on my own. Help with mental health, any other ideals of mental health that I could have had. Maybe it was an unknown to the NHS about the mental health, but maybe now it's more known that these are the aspects to look at. So I used my friends and family network to assist me, and assistance of patient care components as well. So other things to look around this and add them on now should have been then there, thought of, support. Technology. Not everyone has the technology, the telephone, phone calls, the elderly support. They've still got normal home telephone lines. So things like that to come forward. Initial follow-up calls, maybe at 3 months, maybe at 6 months. Languages, BAME, consider these as well. Interpreter service, other organisations that you can refer people who have long-term COVID to. Any of the support networks that are out there, let's use them, let's bring them in, let's stand side by side. Let's help. It's quite easy for these processes to be there. Instead of me asking for them, they should be offered there and then. Can you get a pen and paper? Can you note this down? This is the organisation. Or I can text you the organisation. Or I can email you the organisation. Let's work upon actioning these things so that within, I can have a catch-up call in 3 months' time. In 6 months' time, any other needs and requirements. Before I had COVID, I was a NHS responder service, and I worked in responding the communities and helping all the communities around me. But once I had COVID, I had to just stop where I was and look at trying to get myself better. And I hope that this documentary now has told you the initial of long-term COVID, the implications of it, and the aspects of COVID, just as a recall, and to saying that I think it's a blip in my life, and that if I did have some of the organisations at an early stage, I would welcome them, and I would welcome their support. Anyway, thank you for watching my documentary. I'm Harjit Marwaha, and thank you and goodbye.